Good evening, friends. Welcome to the webinars by easypediatrics.com. Today's topic is neonatal jaundice, a case-based approach. I'm Dr.Maulik Shah. Will take you further into this webinar. Neonatal jaundice, when we see any case, there are three different dimensions which appear in front of us. The first is we divide them into the time zones like early presentation, classical presentation or a late presentation. We also look at the gestation of the child as term or preterm. We also look at them in etiological background by means of either hemolytic jaundice, conjugational error in the jaundice, enterohepatic circulation, or a multifactorial or idiopathic jaundice. This helps us, say for example, looking at time gives us limitations to limit the cause of the particular jaundice and identify it. When we look at the gestation, it helps us from management point of view, simply because the term and the preterm jaundice needs a separate set of management, or their cutoff lines are different when we plot them for the graph. Etiologically speaking, if we quantify or classify them into different categories, then the differential diagnosis will be much more easier. When we say about early onset jaundice can be defined as a jaundice which appears within first 24 hours. When we look at the causes of this jaundice, in first 24 hours, usually we face RH isoimmunization, ABO RH immunizations, and a severe form of Crigler-Najjar syndrome can also be faced. Let's see a case example. A full-term normal delivered female child of 2.9 kg, born of a second gravida mother, whose all clinical examinations at birth were normal, develops icterus at 12 hours of life. The mother's blood group and RH was A negative. The baby's blood group and RH typification was A positive. The history was suggestive that previous delivery went off well, but there was no anti-D taken by mother. The previous sibling of this particular baby was having A positive blood group and RH typification. History of phototherapy required in this particular sib of this baby. The cord blood was sent for the analysis of this particular baby, and it was found to be having following parameters as hemoglobin 12%, bilirubin was 6 mg per deciliter, retic count was 2%, and direct cum test was positive. So the question arises, what would you like to do next? Would you like to investigate intensive phototherapy, exchange transfusion, intravenous immunoglobulin, anti-D to mother, or IV fluid, bolus and antibiotics to this particular baby? What we did was we admitted and investigated and planned a double volume exchange transfusion. At 12 hours of life, the baby's parameters were suggestive like this, that HB was 11%, bilirubin was 10%, retic count was 3%, and the peripheral smear was suggestive of enucleated RBCs and thrombocytopenia. Double volume exchange transfusion was done in this baby. The next question is what to do after double volume exchange transfusion. According to the unit policy, post-exchange we gave this baby intravenous immunoglobulin. The baby was put under intensive phototherapy. A repeat bilirubin was sent after 6 hours, which was 9.8 mg per deciliter. Baby was continued with the same intensive double surface phototherapy. Repeat bilirubin was sent after 6 hours, which was 11. After 24 hours, it was 10 mg per deciliter. Baby was born on breastfeeding and discharged on day 4 of the life with serum bilirubin of 11 mg per deciliter. Next follow-up after 48 hours, for bilirubin check was been done, and bilirubin was found to be 12 mg per deciliter. Now what would you like to do? Well, we called this baby for a follow-up after a week. Baby was not jaundiced clinically. Serum bilirubin and complete blood count were done. The baby was also sent for a follow-up at our high-risk newborn clinic where no neurological abnormalities were detected. Serum bilirubin was 6 mg per deciliter and complete blood count was as following. The baby was again called for a follow-up at 4, 8, 12 weeks of age. Regular clinical examinations and high-risk follow-ups were also been done. The next question to you all is, what investigations would you like to order? Well, at 4 and 8 weeks of age, we would like to look at complete blood count to look for the anemia due to chronic hemolysis of an ongoing cause. At 12 weeks of age, we went for a hearing screening, and also an MRI can also be asked for in this baby at 12 weeks to know the brain damage which could occur secondary to the bilirubin toxicity. RH isoimmunization, a word about it. Well, overall we know that RH isoimmunization was one of the leading cause for bilirubin related encephalopathy and its damages. Nowadays we come across that the incidence is overall reducing. Only 25% of the total cases of the DCT positive cases will have severe incompatibility, meaning to say where the cord blood hemoglobin is usually less than 14 or bilirubin is usually more than 4 mg per deciliter at birth. They usually require extended transfusion. First order of the birth usually do not have much of the problem because the sensitivity which develops takes a little time, and usually the firstborn child is saved from this incompatibility, but they can also develop some amount of incompatibility if the mother has undergone either an abortion or a transfusion of a mismatched variety, and that would lead to a prior sensitization in this particular mother. Hence, the baby who is Rh positive will also get the Rh isoimmunization and later on Rh incompatibility. Often the things what we forget in this Rh isoimmunization status is we forget the anemia which occurs due to chronic hemolysis in these babies at 8 to 12 weeks of life. Cord blood is often not utilized and baby is pricked again and again. So rather than doing a prick of the baby for getting a sample, we should go ahead and take the cord blood sample and utilize it for various investigations like cord blood hemoglobin, baby blood grouping, bilirubin or retic count of that particular cord blood. Prior history of the sensitization like delivery, abortion, procedure or a mismatched transfusion in the mother should be known. AAP nomograms or the charts for extended transfusion shows a little uncertainty in first 24 hours. When most of the RH and ABO isoimmunizations usually present, so there is a little query while adapting to this AAP nomograms, especially in the first 24 hours. The AAP guidelines for extended transfusion as the normogram is displayed here. The basic curve what we are going to follow is this one in this particular chart where the middle one is usually followed. The problem here is shown in this particular square where the area of uncertainty exists. That's why the lines are broken in that particular zone. So we need to use our own unit policies for this first 24 hours while looking at the cases of early onset jaundice. We have adapted one of the chart from the Average Disease of Newborn 8th edition, which we use for deciding for extended transfusion in early onset jaundice, especially Rh isoimmunization. If the cord blood bilirubin is more than 5 mg per deciliter, or the hemoglobin is less than 10 gram per deciliter, or the PCV is less than 30, and there is a history of previous sibling underwent exchange transfusion in a DCT positive status, or if the bilirubin rise is more than 0.5 mg per deciliter per hour, we usually go for exchange transfusion. Subsequent exchange transfusion will also be needed based upon the following findings. Say for example, less than 24 hours and bilirubin is 10 mg per deciliter and rising. 24 to 48 hours, 15 mg per deciliter. 48 hours, the cutoff value will be more than 20 mg per deciliter. This has been adapted from Average Disease of Newborn 837. A word about the role of IVIG. We all know that IVIG has some role to play by preventing double volume exchange transfusions and also reducing the number of exchange transfusions in these Rh isoimmunized babies. It reduces anemia due to chronic hemolysis and about 8 to 12 weeks of life. Its prophylactic role is debatable. The role of IVIG in ABO disease is also not very clear. That's why debating on the IVIG keeps on rolling. A large multicentric trial study is undergoing, and one of the study which has been available is yet to define a specific role of IVIG. Right now, for our resource limited country like India, we need to wait till further multicentric trial study and a concrete evidence comes into our way. One of the studies which I found from the archives of diseases, fetal and neonatal addition, said that the efficacy of IVIG is not conclusive in Rh hemolytic diseases of newborn. The role of IVIG in ABO disease is absolutely not clear, and there is no benefit of using them in ABO diseases as per the study. Regarding NTD administration to the mother, the evidence is very much available to us. It says that antepartum, if we give 1500 international unit or 300 microgram IV or IM at 28 to 30 weeks of gestation and repeat the similar dose postnatally within 72 hours, then the isoimmunization or incompatibility in the future progeny will reduce or do not occur. If both are given, then risk of developing this incompatibility will be reduced up to even 0.1%. Antenatal prophylaxis, we need to remember that if we have given the first dose at 28 to 30 weeks of life, then this particular mother, when tested for a DCT or a ICT, DCT has to be tested in the cord blood and ICT to be done in the mother, both may turn out to be a slightly positive or a weakly positive DAT in this particular baby or mother, and that is even in the absence of hemolysis or even truly isoimmunized or incompatibility status. That we need to remember in our mind. Let's have a word on the ABO incompatibility. Most of the exchanges which have been now required are due to this single reason of ABO incompatibility. It affects 50% of the firstborn child. This is in absolute contrast to the Rh isoimmunization, where we have seen that usually the firstborn sibling is spared. Despite of the documented incompatibility, the exchanges required are only in few numbers. But since the Rh isoimmunization is now well taken care of because of the NTD given regularly to mothers, the leading cause instead of Rh isoimmunization now is ABO incompatibility. Incompatibility usually occurs due to NTA or NTB antibodies of IgG class. Here one need to remember that IgG class of antibodies only can traverse placenta. Hence, the transplacental transfer of IgG class of NTA and NTB antibodies lead to incompatibility development and breaks the baby's RBCs, and hence there is a development of jaundice in ABO incompatibility states. Use of O negative blood, especially using the O negative RBCs dipped into AB plasma, is usually the blood of choice or the ideal choice for exchange transfusion in such babies. Third category or the second category here would be a prolonged late presentation. When we say about a prolonged jaundice or a late presenting jaundice, the definition is usually beyond 2 weeks of age in term babies, while in preterm babies this is little enhanced to 3 weeks, and thus the definition is for the term baby 2 weeks and for the preterm babies 3 weeks. Then we can classify them as a prolonged jaundice. Usually these babies are well looking and well thriving newborns. They are usually breastfed. The serum bilirubin, blood grouping, Coombs test, PS and the retic count all are usually turn out to be normal, but they need to be done simply to rule out all the common causes which might also lead to prolongation of jaundice. For example, ABO or RH isoimmunization can also have a little bit of bilirubin being on the rise or still sustaining even after 2 or 3 weeks. Usually, the causes are continuation of an isoimmunization, Crigler-Najjar syndrome, breast milk jaundice, usually the right variety, and the idiopathic jaundice. Let's take it by a case example. A full-term normal delivered female of 3 kg who was born of a consanguineous marriage by a primary mother was been brought to us. All examinations were normal in this baby at birth. The baby developed icterus onto the sole, reported on day 14 of life, who was active and feeding well. There was no history of any maternal fever. There was no history of any jaundice in the family. Clinically, the icterus was found to be up to sole. The weight on presentation was 2.7 kg. No collected blood was detected, for example, cephalohematoma or anywhere else, which might lead to breaking down of RBCs and increase in jaundice, but there was no collected blood found anywhere. There was no hepatosplenomegaly either in this particular baby. The blood parameters were as shown here. The bilirubin was strikingly high, 33.5, where the indirect segment was 32 in this baby. Retic count was only 1.6, pointing out towards that this was not a case where there was a strong hemolysis. Peripheral smear was mild hemolysis and leukocytosis as well as thrombocytosis. The C-reactive protein were normal, TSH were also normal, G6PD activity in this baby was also normal. So what do you think, what could be the possibilities? Well, again 3 causes are remaining in front of us: Crigler-Najjar syndrome, breast milk jaundice and idiopathic varieties can also present. Since this baby's jaundice was way beyond the phototherapy zone, the baby was taken for double volume exchange transfusion. It was followed by an intensive phototherapy and baby's bilirubin was reduced to 12 mg per deciliter after 24 hours and was discharged then afterwards. The follow-up of this baby after 48 hours was suggestive of a good clinical status and there was no rise in the jaundice. One need to remember here a specific point that this particular AAP nomograms are usually been designed for first 7 days of life. So when we take upon the case like this, which was been discussed here, which was a late presentation or a prolonged presentation, then one need to prolong these lines further towards 14 days or 21 days. Elongating this particular chart or nomogram will further help us depicting the normal levels or applying this nomogram for a late presentation. A very special thing which we need to know about is prematurity. Prematurity with hyperbilirubinemia. Preterm baby, here even we will discuss one case of a preterm baby. A preterm 28-weeker who was been born by an emergency lower segmental cesarean section for mother having pregnancy-induced hypertension. This female born of 978 grams, born of a second gravida mother, was normal clinically at birth, had an event of hypoglycemia at 18 hours of life, but she was asymptomatic at that time. She developed visible icterus on face at 12 hours of life, but she was detected to be having lethargy since last 1 hour. The investigation revealed following things, where the striking elements were a reducing platelet and reducing serum albumin. The bilirubin level of this particular baby was 9, where the indirect segment was 7.9. The C-reactive protein of this baby was also found to be positive with retic count of 2. This baby was taken away for an exchange transfusion immediately. We stepped up his antibiotic simply because there was an elevation of sepsis. The baby was sick and lethargic. So we considered that sepsis could be there in the background and the baby's antibiotic was stepped up. After 6 hours of post-exchange, bilirubin was dropping to 6 mg per deciliter. Subsequently, the baby improved. She was discharged at home at around 4 weeks of life after stabilization of all normal parameters. Follow-up was suggestive that there was no neurological sequelae. Mild anemia was there in this baby, so iron was started according to the unit policy. The baby also underwent a neurological examination and a BERA test at 12 weeks of life, which was normal, and the baby was doing well.